to discuss management of upper GI bleed. And first of all, what is GI bleed? So as Sir already discussed, bleeding from the GIT is considered as GI bleed. It is broadly classified into upper GI bleed and lower GI bleed. And now we have also classified up to ampulla of Vater, ampulla to ileocecal junction, and beyond ileocecal junction. This is upper, small bowel, and lower GI bleed. So upper and lower GI bleeds, any bleeding above the duodenojejunal flexor, that is ligament of Treace, is called upper GI source. Below is called lower GI source. Upper GI source presents with hematemesis or melena, and lower GI source presents with hematochezia, but sometimes melena can also occur in lower GI bleed. Whenever the patient is having massive upper GI bleed causing hemodynamical instability, then patient can present with hematochezia also. Therefore, so basically why? So therefore, to differentiate, therefore, whenever a patient with upper GI bleed, like patient came with melena with hypotension, then patient can, patient is having hematochezia with hypotension. So then we need to do first endoscopy, upper GI endoscopy first, and then we should go for lower GI endoscopy. So if patient is having hematochezia with normal hemodynamic parameters, then you can directly go for colonoscopy. So that is the importance of hemodynamic parameters in a patient with hematochezia. So now we have known what is upper GI bleed and what is lower GI bleed. So coming to what are the causes of upper GI bleed? So the upper GI bleed can be broadly classified on etiology into non-variceal bleed and variceal bleed. So we all know non-variceal bleeds are more common than variceal bleeds. However, the recent literature aims unpublished data shows that variceal bleed is becoming more common than non-variceal bleed. So what are the causes of variceal bleed? Varices are due to portal hypertension. So the portal hypertension most common cause is cirrhosis of liver, and other non-cirrhotic causes are extrahepatic portal vein obstruction or non-cirrhotic portal fibrosis and splenic vein thrombosis. So these are the less common causes of portal hypertension. Most common cause is cirrhosis. In India, the most common cause of cirrhosis is alcohol, followed by hepatitis B and hepatitis C, and then NASH. So coming to the non-variceal causes, as we already discussed, the most common cause is peptic ulcer disease. So the peptic ulcer most common cause is either NSAIDs or H. pylori. So these NSAIDs, how do they cause ulcers? Normally the stomach is protected from the acid effect by mucus layer over the gastric epithelial cells and their epithelial integrity. So this is maintained by prostaglandins in the stomach. So whenever we use NSAIDs, these NSAIDs are COX inhibitors. So they will deplete the prostaglandins and then make the gastric mucosa vulnerable to injury. That is why, as we all know, aspirin is also an NSAID. So aspirin and rest all NSAIDs can cause gastric ulcers by depleting the prostaglandins. And we also sometimes, previously we used to give prostaglandins for treatment of gastric ulcer. Misoprostol, these drugs we previously used to give for treatment of gastric ulcer. Now as PPIs have come, we are not using those drugs. And the next common cause is H. pylori. So H. pylori, it also breaks the mucosal defenses in the stomach and causes gastric ulcer or duodenal ulcer. So basically most common cause is peptic ulcer disease, followed by next one is erosive gastritis or erosive duodenitis. And number 3 is Mallory-Weiss-Stare. Most commonly seen in alcoholics or sometimes in pregnant females in first trimester can also cause Mallory-Weiss-Stare. So the patient typically gives history of excess retching and vomiting prior to the history of blood vomiting. So whenever a patient came with upper GI bleed, he is an alcoholic, he gives history of excess retching and vomiting before the blood vomiting episode, you should think of Mallory-Weiss-Stare. So what happens is, when there is excess retching, there will be a tear on the esophageal side of the GI junction. So that will cause Mallory-Weiss-Stare. So most of the Mallory-Weiss-Stares can be managed by giving PPIs only. Sometimes we need to do endotherapy to control the bleed. And other causes are vascular causes. As Sir have already discussed, the causes like vascular cause includes dilophoid lesion. So dilophoid is a dilated submucosal arteriole in the stomach, generally located in the first 3 to 4 centimeters beyond the GE junction. And other causes are angiodysplasias, which are commonly seen in CKDs or in aortic stenosis patients, and telangiectasias. So even GAVE is also a subgroup of angioectasias. So telangiectasias, we generally see in especially the CA cervix patients, they undergo pelvic radiotherapy. So after radiotherapy, they develop this radiation ectasias in the rectum. So they present with rectal bleed most commonly. Ectasias, and the less common causes are malignancy. Malignancy in the esophagus, malignancy in the stomach, malignancy in the duodenum can also present directly for the first time with upper GI bleed. And the most important causes are iatrogenic, means patient underwent recently an ERCP. So he underwent a sphincterotomy and stenting was done. He came with melena. So that is a post-procedure complication, post-sphincterotomy bleed. And our patient recently underwent a polypectomy. So the polypectomy, after doing polypectomy, patient can bleed. The next patient cannot bleed. One is early and late bleed. Early bleed is within first 2 days. 2 to 14 days is called late bleed. So whenever a patient comes to upper GI bleed, comes to our casualty with GI bleed, we should ask for any history of endoscopic procedure recently done, so that we can know whether it is a post-procedure complication or it is due to the disease. And as also I'll discuss hemophilia and hemosuccus pancreaticus. Hemophilia means there might be a tumor sitting in the bile duct, so that can bleed intermittently and cause and produce lead to bleeding from the ampulla of water. And hemosuccus pancreaticus is most commonly seen in acute pancreatitis, chronic pancreatitis, and pancreatic malignancies. So there will be a pseudoaneurysm that will be leaking blood into the PD, and we will be seeing blood coming from the ampulla via the pancreatic duct. So this is hemosuccus pancreaticus. So whenever there is hemophilia hemosuccus pancreaticus, there is no role of any endotherapy. Directly we should go for IR, intervention radiologist, and he should do embolization of the pseudoaneurysm. So now we have discussed what is upper GI bleed and what are the causes of upper GI bleed. Now let's go what is the management of upper GI bleed. So the upper GI bleed management will be in 3 parts: pre-endoscopy management, and then endoscopic management, and post-endoscopic management. So first we'll start pre-endoscopic management. For example, patient came with GI bleed to our casualty. So always upper GI bleed or any GI bleed is a medical emergency. It's like an acute MI. We can salvage the patient by timely intervention. So immediately attend the patient, check the A, B, and C. Airway, breathing, circulation. If the sensorium is less than 10, you intubate the patient to secure the airway, and then check the BP, pulse, saturation. If he's in hypotension, you will start resuscitation with IV fluids. And the most important thing in casualty is any bleeder comes to the casualty, after resuscitation, take a blood sample and send hemoglobin, platelet, INR, and send one blood group and cross match. There should not be any delay in procuring the blood products in these patients. So DMO should continuously be behind the patient relatives for procuring the blood. Okay. So because any patient with hemorrhagic shock comes to our casualty, the shock will be improved only by replacing the blood products. Okay. So first thing is we will resuscitate the patient. Number 1. Number 2 is we should give some medications. IV medications. So if we look at the background of the patient, if the patient is a cirrhotic, then mostly it's a varicose bleed. Then we should give something to cause splanchnic vasoconstriction. The drug of choice is terlipressin or octreotide. So we give either terlipressin or octreotide. So which drug to give is terlipressin is always the best preferred drug, but this should be avoided in cardiac patients because terlipressin can aggravate the coronary vasospasm. So therefore, should avoid terlipressin in cardiac patients. So in cardiac patients, we prefer octreotide. In non-cardiac patients, we give terlipressin. And other drugs are, if patient is a non-varicose bleed, we should start him on IV PPIs because the most common cause is gastric ulcer. So we should reduce the acid production. So we should give PPI. IV PPI should be given as 80 mg stat followed by 8 mg per hour infusion for 3 days. And number 4 is we should give IV antibiotics. IV antibiotics is generally given only in varicose bleed because in cirrhotics, whenever there is GI bleed, there will be break in the mucosal integrity. So the bacteria can translocate into the peritoneum, causing spontaneous bacterial peritonitis. So therefore, IV antibiotic should be given in all cases of variceal bleed. So we'll restrict the patient. So now, what is the target hemoglobin that should be maintained in a patient with upper GI bleed? So if the patient is a non-cardiac patient, HB should be 7 to 8. If it is a cardiac patient, then HB should be 8 to 9. So why it should not be more than 8 or more than 9? Because giving more blood products will increase the blood volume. Increasing the blood volume can increase the portal pressure, and that will increase the risk of GI bleed. So always we should follow a strategy of restrictive blood transfusion strategy rather than liberal blood transfusion strategy. So it's like in polytrauma cases we follow something called permissive hypotension to reduce the risk of bleeding. So the same strategy is followed in upper GI bleed also. So this is the target hemoglobin that we should maintain, and we should do RT lavage. For example, patient came with melena. So we are not sure whether it is upper GI source or lower GI source. Put an RT. If RT shows blood, it is definitely an upper GI source. Then you should guide to go for upper GI endoscopy. If RT is clear, then it can be either upper or lower. Then we should do upper and lower endoscopy both. So, and we can also give some prokinetics like erythromycin or metoclopramide. So this will push the blood products deep into the duodenum and increase the endoscopic visualization. So there are some risk stratification systems to identify the patient in the low risk and high risk. So some scores are Glasgow-Blatchford score. So this score contains blood pressure, blood urine nitrogen, hemoglobin, tachycardia, melena, syncope, and hepatitis disease. If the score is 0 to 1, he is very low risk of bleeding. There is no need of any emergency endoscopy, and we need not admit the patient also. He can be sent on OPD basis. And another score is AIM-65 score, A for albumin, I for INR, M for altered mentation, S for systolic blood pressure, and 65 is age. If the score is up to 2, he is low risk, more than 2 is high risk. So this by calculating this score, we can tell the risk of mortality to the patient. And the most commonly used score is Rockall score. So this score contains 5 components: age, hypotension, comorbidity, diagnosis, and signs of recent hemorrhage. So if the score is more than 2, there is very high risk of rebleeding and very high risk of mortality. So they should be admitted and should go for emergency endoscopy as soon as possible. So by calculating this score, we can stratify whether it is low risk or at high risk. So as we have already discussed, so you can see the meta-analysis. This is showing restrictive blood transfusion is favoring less risk of rebleeding when compared to liberal blood transfusion products. So coming to the endoscopic management, so all patients with upper GI bleed should be done an endoscopy within next 24 hours. And always remember, proper resuscitation has to be done before taking patient for endoscopy, or else catastrophic events can occur during the endoscopy. So properly resuscitate the patient, give blood products, maintain HB up to 7, and then go for endoscopy. So this is a case of variceal bleed having active spurting of esophageal varices. So we can see there is an active spurt from the esophageal varices. So once the EVL was done, the bleeding has been controlled. So so we have applied the band. After band was applied, the varix bleed has been controlled. So this is a large gastric varix causing upper GI bleed. We injected glue into the varix, and the hemostasis was achieved after injecting glue. So coming to our case, this is ulcer bleed. As we can see, the Forrest classification. So depending upon the morphology of the ulcer in the endoscopy, we classify the ulcer as Forrest 1A, 1B, 2A, 2B, 2C or 3. So Forrest 1A is active spurt. As we can see, this is the active spurt from the underlying vessel. So 1B is active oozing, 2A is non-bleeding visible vessel, and 2B is adherent clot, 2C is flat pigmented spot, and 3 is clean based ulcer. So why should we classify the ulcer by Forrest? Because if it is Forrest 1A, 1B, 2A, 2B, we should do some endotherapy definitely, or else there is very risk of rebleed is there. If it is 2C or 3, nothing is required to be done. Just we can manage him medically by PPIs or antibiotics, etc. So in our patient we have Forrest 1B ulcer, so that's why we have to do an endotherapy in this patient. So what are the different modalities how to control bleeding by endoscopy is mechanical, dermal, injection and topical therapies. So always, so never use injection therapies alone for controlling the bleed, always use a combination of two therapies for controlling the bleed. So the mechanical therapy, as we can see, is a bleeding ulcer. We have applied a hemoclip on the ulcer. So this hemoclip causes mechanical tamponade and occludes the vessel. And after hemoclip, the bleeding has been completely stopped. The limitations of this hemoclip is when the ulcer is too big, or it is callus lesion, or in the technical difficult position like posterior duodenal wall, then the clip cannot be applied. So then we'll come to the savior clip, which is over the scope clip. So this has very good tensile strength and completely occlude the vessels, completely occlude the ulcer from all the sides. So whenever a hemoclip fails to control bleeding the ulcer, then will be going for this OTSC or Ovesco. So other modality is dermal therapy. So in this we can see a coagulation probe is taken and the underlying vessel beneath the ulcer is coagulated by pressing it against the ulcer. And the picture also depicts the same. So as we have discussed earlier, this is a case of CS cervix who underwent radiation. After radiation, she had multiple angiectasias. This is an APC catheter. We are doing APC, which is argon plasma coagulation. So we can see is a non-contact coagulation. So we can see the argon, the electrons are going to the argon gas and they will coagulate the ectasias. This is used for GAVE and for radiation ectasias also. So by injection needles, we inject adrenaline or normal saline or glue. So they will reduce the bleeding by causing mechanical tamponade or vasoconstriction of the adjacent vessel. So this is a case of post ERCP bleeding. So we did an ERCP. So this is a case. This is a bleeding from the sphincterotomy side. So we did dual therapy in this patient. So we applied hemoclip first and then we injected adrenaline in and around the ulcer. So we applied hemoclip first and then we injected adrenaline around the sphincterotomy site. So that has taken care of the bleeding in that patient. So the last line is topical hemostatic aim. So whenever the bleeding is diffused from all the walls of stomach, like erosive gastritis or erosive duodenitis, or there is a malignancy, diffuse malignancy in all the areas of the wall, then we'll spray hemostatic powder. So whenever, so this is useful mostly in malignancy related bleeds. So coming to the post endoscopy part, so if it is varicose bleed, we will continue terlipressin for 2 to 5 days. If it is ulcer bleed, then we, depending upon the Forest classification, if it is 1A, 1B, 2A and 2B, we will give PPA infusion for 3 days. If it is 2C and 3, we will give oral PPA for 8 weeks. So coming back to our case, in our case, it's basically a 55-year-old female who is CAD with triple vessel disease, who underwent CABG on 3rd of November. She came in next 2 weeks with upper GI bleed, hematemesis and melena, with HB of 5.0 and INR normal, blood urea 25. So basically what we did for the ulcer is we injected adrenaline into the ulcer and we applied hemoclip on the ulcer. And the next day we did relook endoscopy. There is, at the time of first endoscopy, there is a lot of altered blood and blood clots in the stomach and duodenum. And we did hemoclip and injected ADR around the ulcer. Ulcer is at the lesser curvature, just below the GE junction. So it is 1B ulcer. So in the next, on the repeat endoscopy, there is no hemoclip is in situ. There is no altered blood or any blood drop in the stomach. So patient discharged after 3 days, and she also came 1 week after discharge. She was absolutely fine. There is no, she did not show any rebleed on the follow-up also. Second look endoscopy is not mandatory always. It's up to endoscopy discretion. We did on the next day. So on 19th afternoon we did first endoscopy. 20th morning we did second endoscopy. That showed there is no blood drop. It's completely bloodless endoscopy in the next day. So the questions in this are: should we transfuse blood? HB is 5. And she's a cardiac patient. Our target is 8 to 9. So we gave her 3 or 4 PRBCs and maintained HB at 8 before doing endoscopy. Number 1 to do endoscopy. So we stabilized her with blood products and eye fluids, and we did endoscopy in the next 6 hours. So whether endotherapy has to be done or not, as ulcer is Forest 1B, so endotherapy has to be done. So we applied hemoclip and injected ADR also. And she is on dual antiplatelets. So on aspirin and clopidogrel. So the question is, should we continue this or not? So as she is a very high risk patient, generally we stop clopidogrel, continue aspirin. And the question is when to restart the antiplatelets in these patients. For example, a patient came with upper GA bleed or any GA bleed, he is on dual antiplatelets. First we will see whether he is high risk cardiac patient or low risk cardiac patient. High risk means he had recent PTCA in the last 3 to 6 months or CABG in the last 3 to 6 months, or he had recent MI which is managed medically in the last 3 to 6 months. They are very high risk, so we will stop only clopidogrel. We will continue aspirin in these patients. If he is low risk patient, then we will stop both the drugs. Okay. So next question is when to restart. For example, if the patient is having 2C or 3 forest ulcer, we can restart immediately after the endoscopy. If the patient is having either forest 1A, 1B, 2A or 2B ulcer, then we so once we are pretty sure that blood has been bleeding is completely controlled, then for aspirin we follow the rule of 3, 5 and 7. For aspirin 3 days after, for clopidogrel we take 5 days, and for anticoagulants like warfarin, dabigatran and aspirin we take 7 days. So this is the timing of when to restart the drugs. If the patient is like high risk, like patient is a rheumatic heart disease, he is on MBR. If you think that the risk of stuck valve is high, you can start early also. So to summarize, whenever a patient comes to GA bleed, so restrict the patient, stratify into low risk or high risk, admit him and give him blood products, maintain HB between 7 to 8, give erythromycin and prepare for endoscopy. Once endoscopy is done, depending upon forest classification, you will give the required endotherapy or not, and then after 3 days you can discharge the patient. Thank you.